Hello, I'm Eric Topol, Editor-in-Chief of Medscape, and with me today, really fortunate to have Dr. Laura Esterman, who heads up the breast cancer program at University of California, San Francisco, and who has really been pioneering a whole different path for breast cancer, and actually even bigger than that. So welcome, Laura.
Thank you so much for having me.
So I know your background is interesting. You were at Harvard for undergrad, you were at Stanford for your medicine, surgery, for MBA. And then you have been 20 years running this program, breast cancer program at UCSF? So over this period of time, there's been a lot of changes, and there's still a lot of controversy of how to manage breast cancer. What's your take on all this?
Well, when I started this program, I had an idea. There were a couple of things that I really wanted to create. I wanted to create a place that really served the women who had breast cancer, and really to create a place that was one-stop shopping, that was really organized around patients, to have a very high-touch, patient-centered program where all the different specialties would revolve around the patients, where we would really think about innovation in decreasing morbidity, complications, really improve the specificity of what we are treating, and really create a team that was interested in innovation. And some of those things we've been able to do very well. Some of them actually, in order to really drive innovation, you need actually a bigger platform. You need to have sort of more, a larger, more population-based focused. And I think that the lesson of biology is that one size doesn't fit all, that cancer is not one disease, and actually some of what we call cancer isn't even cancer.
Right, we're going to get into that.
And so part of the problem is you have to, if you really want to make progress, you have to really get your denominator right. And I think the other thing that I've been really pushing for, I'm sad that it's taken me so long to get there, but to really make sure that people had feedback on performance. When I've always had this, now people call it precision medicine, but my idea was always to say that we should treat people based on biology, patient preference and situation, and clinical performance. And to try and figure out how to get the resources and the structures in place to allow that to happen. Because I think if you have that, then you actually are going to do the best with what you have. You'll be able to work together to create a better future, and be able to create that future by constantly being able to look at and improve your situation.
Right. Well, there's no question that you have been emphasizing this individualized approach at multiple levels, but also maybe termed a rebel, that is fighting the status quo.
Right.
That is, let's go into a very important area of the ductal carcinoma in situ, which I think you would prefer to have it perhaps renamed and re-identified?
Correct. So I think that, all ductal carcinoma in situ in many ways is a disease we created because of screening.
Mammography.
I think it's important for us to put screening in perspective. And it's not, is screening good or bad? I think let's understand what made us think that screening was a good idea. What have we learned with 3 decades or 4 decades of screening, not just across breast cancer, but breast, prostate, cervical, lung, colon? What are the lessons we've learned? And then how do we then apply it? And let's try and take some of the emotion out of it. For some reason, I think, and I think I understand why people react the way they do. And I'm not for or against anybody. I'm trying to create something better for patients and for women, right? So back in the 70s and 80s, we were looking at this from a population basis. The people who had cancer in stage 3 and 4 did much worse than the people who had stage 1 cancer. So it stands to reason, if we could only find that disease earlier, we would do a much better job. We would prevent death. So that assumed, however, that cancer was one disease. So that was a long time ago, and that's what we thought then. But in fact, we've learned so much more. Cancer is very complicated, it's heterogeneous, and if we accept that scientific reality, that has to impact our clinical practice. So what have we learned? We have learned that, in fact, there is a range of behavior from indolent to very aggressive, and that the more...
And most are indolent.
Well, not necessarily most. It depends on the cancer type.
Oh,
and the
the
problem.
DCIS mean?
Yes, most are indolent. I think
And that's
so.
why you want to call it idle or
Yes,
something?
indolent lesions of epithelial origin. And the problem is if you screen, you are necessarily going to find this reservoir of indolent disease. But the problem is we see it and go after it. And part of the problem is that I think people understand this in prostate cancer. And here, actually, screening may make more impact on prostate cancer than it does in breast cancer. But the problem is there is more indolent disease. And when you screen, you find more indolent disease in prostate cancer. So people understand that. In breast cancer, especially young women who have more aggressive disease, that's the face of breast cancer, and people are very frightened of it. And it's not that it's not a serious disease, but you don't help the people with more aggressive or serious disease by overtreating the people who are never going to get there.
Right. Well, you get a lot of women, I'm sure, who are referred to you, who've been already told you should have bilateral mastectomy.
I do.
And you say, time out. Right.
Right. Well, my email is full of this, and I get calls, and actually, women themselves seek me out, not just referrals. And I think for sure, we assumed that DCIS was an obligate precursor. That's how we thought. But think about cervical cancer for a minute. We used to call it cervical carcinoma in situ. They changed the name to CIN, cervical intraepithelial neoplasia, because it made people just pause and not be so aggressive. And where are we now? CIN1, if you watch it for a year, 50% of those lesions go away. Yeah. So this is the lesson. These are not, oh my gosh, if you don't do this, your breast is going to come off and you're going to die. We have to stop telling people that, because we have no basis in fact for that. All we know is this might or might not progress. This is not... And it itself is just a risk factor. And low-grade DCIS, the reason why pathologists probably can't tell the difference between atypia and low-grade DCIS is because they're the same thing.
Sure.
Biologically, they're the same thing. They are a risk factor. And we should think about, do you have any other risk factors? Are there things that we can do to reduce your risk? What about endocrine risk-reducing therapy? We spent hundreds of millions of dollars on prevention research. Why not apply it here? Why not start figuring out who's at risk and who's responding to these features, and start thinking about alternative therapies. And I also wonder why it is that we are accepting of interventions without data, but are anxious to withdraw interventions when we have no data to suggest that they are working. For example, there is no evidence that we make a mortality difference with radiation for DCIS.
Right.
So with the exception of some very high-risk situations, why are we radiating people with DCIS and using up and that's actually something, even though that risk is very low, its mortality impact is probably not zero.
Sure.
Why are we doing that?
Well, I'm glad that you're questioning that. I actually think the questions here go even more broad. I think that what you're saying, though, the model of breast cancer applies, as you've already asserted, across many other cancers.
Oh, absolutely.
Prostate is a perfect example. There's many others where we overtreat. We just do too much. We overreact, and we don't appreciate the individualized story here. But why do we do mammography routinely? This seems really crazy. The data suggests there's a net harm that's really profound.
Well, so I think you don't necessarily want to throw the baby out with the bathwater.
Okay.
Right? So I think one of the things to do is figure out who's at risk for what kind of cancer and which groups and which populations of people should be screened. Just as today, no medical oncologist would treat, or no surgeon would treat everyone the same with breast cancer.
Right.
Why are we screening everybody the same?
Yes.
That cannot make sense either, right?
I know you're working on a really big cohort of wisdom.
The wisdom study, yes.
Hundreds of thousands of women to understand this better. But just yesterday, there was a JAMA Oncology paper of 37,000 women with 92 SNPs. They could sort out risk of mortality in breast cancer from 3% to 25%. So we know there's better ways than just clinical data to do this, right?
And we are doing that.
Yeah.
So in the wisdom study, we're actually using 257 SNPs.
Sure.
But so we're taking the Breast Cancer Surveillance Consortium model, which has been validated in 1 million people. Now we've validated it with the SNPs. That's the paper that, these are these SNPs that we're talking about, these small variations. But there's also probably 9 genes, not just BRCA1 and 2, but 9 genes that are associated with significant risk of breast cancer. And it's not that that's the majority of the population, But my goodness, in that 1 to 2% of the population that's the group that has the most risk. So let's make sure we get those. Let's add breast density exposures, the SNPs, and put that into a model and do two things. Let's identify the groups of people who are most at risk. We'll make sure that we screen them. Make sure that we think about prevention. We should integrate screening and prevention. There are many tools. These SNPs also tell us, are you at risk for ER negative disease? Are you at risk for ER positive disease? And you can imagine if we started to figure out, as we're starting to figure out what is actually working to treat some of these hormone receptor negative cancers, and and many of them probably have something to do with the immune environment, if we can understand who's really at risk for them, maybe we can start to think about it. Maybe that's where we think about the microbiome. That's where we think about all these things. We can think about prevention. So what we want to do is sort out we're starting with a framework that's within the U.S. Preventive Task Force guidelines, right? Because we don't have really room to do it differently. But we're going to adapt over time.
Yeah.
That we're going to learn. I'm not going to start with a model that 20 years from now everyone's going to argue about. The whole idea is to have living learning systems and adaptation.
Absolutely, but you have been a standout. You are somewhat of a maverick because the rest of the breast cancer surgical medical community is much more aggressive. They're not exactly adopting this less is more position, wouldn't you say?
Well, the funny thing is, I'm not a therapeutic nihilist. I actually believe that, on my other hat, I run the I-SPY trial, right, where I'm really trying to figure out how to do better for the people at most risk. By the way, last I checked, there's still 40,000 women a year dying of breast cancer. People don't like the treatments that we have to offer. So as far as I'm concerned, until we get those numbers down and the morbidity of our treatments goes down, we have a long way to go to improve what we're doing. And if you keep doing the same thing, how are you going to make it better?
That's a key point. There hasn't been a substantive change in the landscape here, right?
Well, I'm starting to see a sea change, and I'll tell you another thing that I'm really working on. So again, right, so more is not better, but people feel that that's an emotional reaction. Oh, I did everything I could. I'm going to fight it. I'm going to really do everything I can. But more is just more.
Yeah.
And sometimes more is worse.
Yeah.
So the MINDAC study, let's talk about that for a minute. So they spent 70 million euros on this trial, and they're really trying to say, look at the people who have the 70 gene test that is low risk. And it doesn't mean low risk ever. It just means this low early risk. And they're trying to say, does chemotherapy really help these people? And they set as their primary endpoint that there would be less than a 2%, that they would have like there would be less than a 2% variation in that outcome of 94%, so that the survival of this group is 94.7%, so that it was with confidence, it was above the 92.5% survival. So the maximum benefit you could have from chemotherapy in that group, as they showed, for low-risk patients with up to 3 positive nodes, was 2%. Now, if you want to do chemotherapy for that benefit, okay, go have at it. But, but I will bet you that a lot of people will say, oh, they didn't absolutely prove that there was no benefit.
Right.
So just my point, take it to patients.
Yeah,
really.
Give them the choice.
So here's the thing. We already know that people with proliferative disease, the higher the proliferation, the more the chance that chemotherapy is going to benefit. The lower the proliferation, it's not that you don't ever have risk, but what's going to help you? Endocrine manipulation and other targeted therapies that are coming along.
Right.
And the thing is, there's going to be enough. People talk about how expensive all these new therapies are.
Yes.
And I say, honestly, if we just stop doing the things that we do every day that actually don't have that much value, there's plenty of room to pay for new things.
It sure seems that way.
So, for example, radiation therapy for women over 55 with luminal A disease or people over 70, for sure. I just got asked. I gave a talk to the internal medicine review course on yesterday morning, all about screening across, all the 5 major cancers, and gave some great examples around DCIS. This woman came up to me afterwards and said, oh, I have this woman who had about 1.5 centimeters of DCIS, and she had a little bit of microinvasion, strongly hormone positive, and they want a radiator. I said, if she had an invasive cancer that was 2 centimeters and she's strongly hormone positive, there's no indication that radiation has any improvement in mortality. So why would you do that?
Right.
So this data, I gave the discussion at ASCO in 2005 over this data. There was in the New England Journal. Why is it?
Only 10 years ago, yeah, well, plus. Well, I
Why
applaud
is it that
you
we
for
can't
asking these questions.
But so what? But the
Yeah.
thing about it is, we have to say. But I think people are afraid, and we make them afraid. As the physician community, we're afraid that we'll be blamed if they have a recurrence or something bad will happen. If anything, you can't prevent bad things from happening. You know, bad things happen all the time. That's not in our purview.
But I think what you're really getting at is by having as much information about the individual as possible, you would minimize your chances of doing that is going to be a better outcome. Of course, giving choices. I wanted to get into something that you do that's pretty unique beyond medicine, singing to your patients. So is that a frequent thing that you do?
Every person I operate on.
Really?
And they actually can, if they have a song that they like, they can request it.
Wow.
And I tell them if it's an aria, they've got to give me a week. Otherwise, I can learn it the night before, usually
So
20
you-
minutes
you
before.
must
But I
have-
know a lot of songs. So
Oh my gosh! So have you been singing for a long time?
I've been singing for a long time. So it's my hobby. It's my avocation. So I love to sing. Actually, someone asked me to sing the song from Hair the other day from Good Morning Starshine. It's such a happy song. It was so great. And you see the mood. It's something that was meaningful to her. I sang it. Actually, a couple of people in the operating room sang it with me, and it changes the culture, changes
So
the
you mean
dynamic from a
this-
scary operation
Yeah.
to something. Now this is something where everyone's focused on that patient. You sort of change it from being this horrible, scary.
Yeah. So
Time.
so the person comes in the OR before they're actually put under.
Yeah, I'm the pre-anesthetic induction. So everybody falls asleep on me.
And so, does anybody say, "I don't want you to sing," or this is
No.
this is a routine? Yeah.
That's a routine.
And
Nobody.
you've been doing this for all these years.
I have. It started one time when I was an early attending, and someone had a complication. We were waiting for the anesthesiologist to come in the room, and everyone was just really anxious, and I was anxious. The patient was getting more and more anxious, and she was on the blood pressure monitor, and I couldn't think of anything else to do, and I'd just seen Phantom the night before, so I just started singing.
From Phantom, or
From Phantom, All I Ask of You, which is a beautiful song.
Yeah,
right? And it starts
sure.
like No More Talk of Darkness, and so they, and her blood pressure dropped about 40 points, her systolic blood pressure.
isn't that
And I'm
amazing?
sure mine did too. So I thought, and she told me afterwards that was the most incredible thing that had happened to her. So I thought, now I can blend something that is another skill that I bring to the table and I love, and something I love to do. And
it's fantastic.
but I think what it does is it creates a connection that you're doing something for them to take their mind off of what's about to happen, and you think about something that's meaningful. It's moment. I mean, this is the wonderful thing about medicine is the relationships you create. One of the songs I particularly love to sing is the song For Good. And it is about how you've been changed for the better because of the people that you know. And the experience that you've had. And I think that's true as a physician, right?
Sure.
Every person you meet changes you and informs you. It's part of your own heuristic about how you can tailor treatments to an individual person. And if someone says, I really don't want to have this, I don't say someone refused therapy. I say this person was told
Given
what
all
the
the
choices were,
information,
and here are the options.
Yeah.
And if they don't like what we have to offer, that's their choice. And if you give someone a choice, you have to allow them to make a choice that you wouldn't make. It's not you. It's not for you. It's for them.
Sure.
And
I'm totally with that.
and I think that's the essence of what I do. I don't browbeat people into doing what I think they should do. I can advise them and try and explain the outcomes, but they have to make their own choices.
Well, it's really refreshing. You really question a lot of the sacred cows in medicine and surgery approaches. I think it's fantastic that you've been recognized. Recently, you were Time 100, one of the most influential 100 people in the world, not just in medicine, but in the world. I think congratulations on that.
Well, thank you.
How was that event of celebration?
It was a lot of fun, and
You met a lot of interesting people.
I met a lot of
imagine.
very interesting people. I also met Trevor Noah, which was very exciting.
Yeah.
Someone I admire quite a lot.
Yeah.
John Stewart and Trevor Noah. And because I think these are people who say some of the things that should be said and make us think and make us question. I think Melissa McCarthy had made some remarks just saying that I think people were picked because they were iconoclasts and
They're out there a little bit.
and out there, but making people think
Yeah.
and making people change. And I don't say that I'm right. I say let's have these ideas have their day in court and let's test them. You know, in the wisdom study, I'm saying I think personalized screening is the way to go. I don't know that. You know, if the radiologists say, we think annual screening is right, the primary carers say something else, and the people who are paying for care say, well, I don't like, you know, and everyone's fighting and putting people in the middle. And someone's sending a letter, come back every year, another physician sending, come back every other year. Women deserve better. And we should aspire to better. Why are we arguing about data that's 40 years old? Let's have at it and have a real trial and let's learn. But more important, let's have something that learns.
Yeah.
Where we take the data, we can keep improving the model. I didn't say I was going to test this model today. I said I'm going to keep testing the best risk model that we have at the time. And let's turn this into a living registry. In the same way, in the I-SPY trial, you know, look, if you give people adjuvant therapy, that means you treat them, you take away the biomarker, which is the tumor, and then you give them therapy. You can figure out for that population of patient who works, but you have no idea how it worked for that individual. And while it may not be perfect as an indicator of how well that treatment worked, it's so much better than having no idea. Why would you ever do an adjuvant therapy trial? Learn, because the order of therapy doesn't make a difference in outcome. Let's learn. And then let's take that data and figure it out. I mean, here's something that's very interesting. Here's our paradigm. If A is better than B, we always go for A. What if A is only a little bit better than B? But B is so much less toxic.
Well, and also A better than B at the population level. You know.
Exactly.
Come on.
So we just graduated TDM1, which is it's a drug that doesn't. It's the toxins attached to the antibody that targets HER2 positive breast cancer. It graduated from I-SPY. Strong chance. I mean, it's definitely better than Taxol Herceptin. And it's probably about the same as Taxol, Herceptin, Perjeta. Right? So, but it's so much less toxic.
Sure.
And the other thing, too, is we give everybody AC afterwards. That's the way we've done it. And I think going forward for the future, why wouldn't we say, wait a minute, if we can get 40 to 50% of these people who would have had lethal breast cancers to a complete pathologic response without anything other than this relatively non-toxic regimen, or that plus other biologics, why would we not want to go that direction and then take the people who need more and give them more? To me, that's so exciting. But everyone is afraid, like, well, how do you know that's really going to work? And, you know, that's not perfect and they could still die. And I'm like, really? Why? I mean, maybe I just think differently. But
well, no, I think clearly you're passionate about it.
Isn't that what women
You're asking
would want?
the right questions. You're doing what I think is the right thing for each individual patient, and I think that's why we want to recognize you as one of the most interesting people in all of medicine. So that's why you're here.
Well,
Thanks
you.
so much, Laura, for joining us. Thank you all at Medscape for tuning in on this one-on-one interview with really a rebel who's really, I think, in a great way, shaking up medicine, cancer, breast cancer, and much bigger than that. So thanks very much, Laura.
Okay. Well, thank you so much.